Hi, welcome. I'm so glad that you have clicked to watch this webinar. I am Sarah, and I am going to talk us through how to support your client through an induction as the doula. So I'm just really glad that you're here, and I hope that you learn a lot. Okay, a little bit about me. I'm Sarah Osborne. I have been a birth doula since 2008. I have been to about 900 births in that time frame. I am married, I have 3 kids, and I have 3 cats. And I live in Tacoma, Washington, which is just about 45 minutes south of Seattle. I've been here my whole life. I love coffee a lot, which is such a Seattleite thing to say. I also love cats. I love Disneyland, especially. I love birth. I love babies. I love music. Yeah, I just love all the things that are fun in life, like parties and friends and gift giving and all of that. If you know the Enneagram at all, I am totally an Enneagram 2, wing 3. And so that's just a little bit about me. I am also one of the 3 doulas that makes up the Birth Collective. And we are a trio of birth doulas and birth photographers that serve the Seattle-Tacoma area. So I'm going to talk all about inductions, and I'm going to cover a lot, but I'm not going to cover everything because that would probably be like a 3-hour webinar. So I'm going to cover the basics, and hopefully you'll learn a lot. But know that if you have questions, or if you have like a specific scenario or situation that you're curious about, I'm always happy to chat about that with you. You can send me a message on social media or an email or whatever. I'm happy to support you in whatever that looks like. Okay, let's dive right in. So your client needs to be induced. Now what? Inductions happen for a variety of reasons. Sometimes they're medically indicated. There's elective. There's health conditions that might warrant an induction, or sometimes a placenta issue or an issue with baby. There's all kinds of situations and scenarios that you're going to find like is the reason for an induction. I kind of have 3 categories for inductions, and most of them are going to fit into the middle category. Okay, so on either side, you're going to have over here is medically induced inductions. Oh my goodness, that's not what I meant to say. Medically indicated. So these are going to be situations where, like, there is a reason, this is important, baby needs to be born, there's a health concern. And so that is like a non-negotiable, this needs to happen, this is important, it's very medically indicated. Okay. Then we're going to have on the other side elective inductions or patient preference. Maybe like they're tired of being pregnant, or their comfort zone is like 40 weeks. I want the baby out because I'm too stressed out about going past that. Or maybe their provider's going on vacation and they want their provider to be there, or their mom's in town, or what, like there's a host of reasons. Okay, that would be very much an elective patient preference induction. And then you have this big, huge gray area in the middle, and that is where I think most inductions fall. And that is where it's a situation that your provider could find a reason to call it a medically indicated induction, but is it really? It's kind of their opinion on that. So things that would fall into that category would be like, maybe the mom is overweight or has a high BMI, or maybe they did IVF, or maybe, they think the baby's too big, or what, like all this kind of stuff where like you might get a different answer if you talk to different providers, and that's because it's their opinion and it's not necessarily a solid medical reason. It's more like, yes, we could back this up, medically speaking, that this is a reason why we're inducing, but also there is some wiggle room. It's a gray area where you have choice. And a lot of parents don't know that. They tend to just defer and refer to their providers when it comes to that. And I always kind of step back and say, okay, if this is the reason that we are inducing, and this provider says absolutely yes, this different provider says, you could do it or you could not do it. This provider's like, I think it's totally fine and safe to wait and let them go into labor on their own or whatever. If you're going to get like a variety of different answers and opinions from different providers, then that's a definite like indication that this is a gray area. So that might be helpful for you to know and kind of use that to talk to your client, possibly, depending on the situation. So, what can you do as their doula? If you find out that your client needs to be induced, I would ask her, how does she feel about that? How is she feeling about this induction? And listen, just be quiet and just let her talk. Sometimes people need some pause and some quiet before they really divulge what their true feelings are. And then ask her if she wants more information, if she needs help making decisions, or gathering questions to ask of her provider so that she can make more informed decisions. Really make sure she is set up with all of that info and how to move forward. And then ask her, how can you as her doula best support her? And you might be surprised at what she says. And if she doesn't know and she doesn't have an answer to that, that's okay. But encourage her to think about it and get back to you. And maybe then in a couple of days, ask her again and see if she has an answer. In the US, about 1 in every 3 births is an induction. So it is a lot, and you will for sure encounter this as a doula. As your doula, remember that you are not there to save her from this induction. You are not there to try and prevent it or sway her in any way. She needs you now more than ever. She wants to know you support her no matter her choices, that you aren't judging her, that you're in her corner. You should keep your personal opinions and biases to yourself and show her the unconditional love and support that she deserves. She needs you, and she is so lucky to have you as her doula. Okay, we're going to talk about the Bishop score. And this is like a scoring system that your provider would do a cervical exam to gather information on all these key points. So, the position of your cervix, the cervical consistency, your effacement, your dilation, and where the baby is in your pelvis, which is station. And it kind of spits out a number for all, like a point system for all of those things. And then it gives you, if you look in the middle, where it says important, 6 or less means it's an unfavorable cervix, which is not a great idea to do an induction on an unfavorable cervix. If it's 8 or more, that is considered favorable. And if it's 9 or more, that is ideal. So what this scoring system does is it kind of tells you, there's another chart that I don't have in this slideshow, but I think you can Google it, and it will actually tell you based off of what the Bishop's score is. It'll give you like a percentage for how likely this induction is to end in a vaginal birth versus a C-section. I think that can be really helpful to show your client, to kind of say like, hey, especially if it's more elective or more of a gray area, like maybe her cervix is a bishop score of like 7, which is kind of in the, like 6 to 7, kind of unfavorable, not super great. And maybe it'll tell her what her chances of ending in a C-section are, and sometimes that can be give them pause to be like, oh, okay, maybe I need to reevaluate, or maybe I really need to kind of like think about what I'm getting myself into here. I think inductions are really misunderstood by parents, and in my experience, providers do not do a good job of explaining to them what does an induction look like, and people have really bad expectations. I think that they think, oh, I show up, I check in, they're going to put me into labor, and then I'm going to have a baby. And they don't know how hard and how long it can take to put a body into labor, and that the chances of interventions and epidurals and all these other things are way higher than if you went into labor on your own. The chances of C-sections are even higher. And it's a super long process that people aren't really expecting. So it's a big jump from going into birth thinking, I would like to go into labor on my own, and, whatever their pain management is, that doesn't matter, whatever. But a labor that's induced is going to be very different from a labor that starts on its own. Okay, coming back to this bishop score, if you look at the top left picture where it shows that posterior cervix and an anterior cervix, the cervix starts out posterior, which is facing like towards your butt, and then it slowly moves anterior, which is pointing towards your vagina so that your baby can be born and come out. That happens towards the end of pregnancy or in early labor. It slowly will move forward, and that is one important piece. A lot of parents have no idea that is even a thing. So good to talk about. Your cervix also is going to change in consistency, and it's going to go from firm, which is about as hard as your forehead, to medium soft, which is about the tip of your nose, to soft, which is about as soft as your lips. So changing consistency from forehead hard to as soft as your lips is a huge difference. It's also going to thin. So a normal non-pregnant cervix is about 2 inches long or thick, and that would be 0% effaced. Effacement is told in percentages. So a normal 2-inch long cervix is not effaced at all. 50% would be like halfway, so 1 inch or so. And then 100% effaced is paper thin, like your cervix is as thin as a sheet of paper. So again, huge changes that the body has to do. And then there's dilation. That, of course, is what everybody focuses on, is how many centimeters am I? And, is it time to push yet? And all this stuff. That is just one little tiny piece of the puzzle. Your cervix has to do all that other stuff too, not just dilate. And really, it has to do most of those other things before it can start dilating. So we want a cervix that is forward, soft, thin, then we can start dilating. And then your baby's station is how low that baby is in your pelvis. So the negative numbers are like a floating baby that's very high in your tummy, and then once they're at 0 station, that is where their head is engaged in the pelvis, and then those plus numbers are starting to come out. So like in the birth canal and on their way out. So +4 would be like crowning. We can see your baby's head from the outside. I like to equate your cervix to a cube of butter. So if your cervix, imagine, is the consistency of a frozen stick of butter, when contractions happen, your uterus is going to contract. Like medications like Pitocin that make your uterus contract, those are going to work every time. But it's not just contractions that we need. If we're causing contractions, but your cervix is not ripe and ready, it's kind of like having contractions against a brick wall. That brick wall or that frozen stick of butter is not going to budge. We want that butter melty, soft, and gooey so that when you have contractions, it's going to open and open easily. So imagine your cervix, and this is a good analogy to share with your client, is a stick of butter. And when you are at the end of pregnancy or you haven't started your induction yet, it's frozen. And if you have a frozen stick of butter, try to put your finger through that. That's not going to work. And that is what contractions are. They're dilating, opening, putting your finger through. If you have a stick of butter that's been sitting out on the counter for like an hour, you might be able to put your finger through a little bit, but it's going to be not very soft, still not work super well. And then imagine you have a stick of butter that's been sitting out on the counter all day long and it's 80 degrees outside. It's going to be super easy to stick your finger right through it. It's just going to open and glide and be mushy soft. That's where we want your cervix to be. And this is why cervical ripening is hugely important before an induction. We want as much cervical ripening as possible so that then when we add and start contractions, your cervix is going to respond and open and dilate. We're going to talk through a lot of the common ways for cervical ripening. I'm not going to talk through every single option, but these are definitely the most common in the US. So cervical ripening is the process by which the cervix softens and opens before labor begins. It occurs through a series of biochemical processes that realign collagen molecules, causing the cervix to thin, soften, relax, and dilate in response to uterine contractions. So the most common options are Cytotec, which is also misoprostol or miso, Cervidil, the Cook or Foley balloon or catheter, and then there's laminaria or Dilapan, which is same thing. Okay, we are going to touch a little bit on each of these. So we'll start with Cytotec, which is miso. This is one of those things that people have a lot of feelings about Cytotec because it has gotten kind of a bad rap, kind of like Pitocin. It's like scary. Maybe people have heard horror stories or they Googled it and read all sorts of stuff maybe they shouldn't have been reading. So I will say Cytotec doesn't have a great history, but I'm talking like 50 years ago. And that's because they were not using it appropriately. And so there was a lot of like uterine ruptures and, even deaths reported with Cytotec. That is not happening anymore. And it's because now we have figured out how to safely use it. And we have parameters around dosing and like who's a candidate for Cytotec and for how long and all of those types of things. So I personally love Cytotec. You might not find a lot of doulas that say that, but I do because they work really, really well. And I would rather get Cytotec and have a beautifully, straightforward induction if needed, rather than trying to avoid it and possibly ending up with a C-section. Again, that's everyone's own opinion to make. That's just my personal preference. So with Cytotec, usually it depends on the provider, but their tablets they'll either take them orally or vaginally. They are used for the induction of labor for cervical ripening. And the usual dose is about 50 micrograms orally or 25 micrograms vaginally, which can be repeated every 4 hours if the contractions aren't too frequent. So this will cause like some cramping, some contractions, but they're like little kind of baby mini contractions. They're not like the huge active labor contractions that people need like help coping with most of the time. So what the disadvantage of Cytotec is that it can cause overstimulation of the uterus, which means you're going to have frequent contractions that are too frequent or too close together. If that happens, they're going to stop using it and they're going to move on to something else. It is used off-label for induction, so Cytotec isn't made for labor induction, but that is like obviously this is one of the side effects is that it softens and thins your cervix and can cause contractions. So what I notice is that the doses tend to like build off of each other. So my recommendation to my clients is that get as much Cytotec as they will give you for as long as possible. Usually you can get like 4 to 6 doses, and that's a long time. If those are 4 hours apart each, that could be like half a day to a whole entire day of just taking Cytotec. Nothing else is happening. You're in the hospital being bored and waiting around. So that is like kind of the bummer, but if that's working to prep and soften and efface your cervix, it's worth it. Usually, providers have you be on continuous monitoring while you're on Cytotec, or at least for like the first 2 hours of the dose. You cannot use this if you are a VBAC client because as this is thinning the cervix, it can also thin the scar on your uterus, which is not what we want. So it is not for use in people who have had a C-section before. Okay, then there's Cervidil. Cervidil is another agent that can help like soften and ripen the cervix. It uses a natural substance that your body makes in preparation for labor, which is a prostaglandin. It releases, it's kind of like a tampon that they insert up next to your cervix, and it releases medication over a 12-hour period. So sometimes they'll do another dose, like they might leave it in for 6 hours and then put in another one. Usually you have to stay laying down for the first couple of hours after it's placed. Often Cervidil is really, really irritating to the vaginal tissues. So that is probably one of the bigger cons of Cervidil is that it can make your vagina like really not feel good and hurt when people are doing an exam and those types of things. Again, continuous monitoring is usually required. Cervidil is really expensive, and so not a lot of hospitals even have it in stock or offer it as an option. They usually tend to offer Cytotec instead because Cytotec is much cheaper. So again, this is at least in the Pacific Northwest. I do not see this ever being offered for a VBAC client. However, I have heard a nurse tell me that they did use Cervidil for VBAC patients when she was a nurse in California. So I don't know if other states are sometimes using this for VBACs. I haven't heard that. So that was like new news to me recently, but you'll have to report back. Like if you are from out of Washington State, if you have seen Cervidil used on VBAC clients, I would love to hear about it. So let me know. And then there are laminaria sticks, or Dilapan is also what it's called. They are thin, sterilized, dry sticks of seaweed that are inserted into the cervix. So again, kind of like a tampon, but it's like not in the vagina, it's like in the cervix. So even further. And it helps to dilate your cervix. So what it does is that seaweed absorbs fluid and moisture from the surrounding tissue, and it expands as it absorbs that, kind of just like a tampon. So it can go up to 10 times its original size, and it stays in place for about 12 to 24 hours. When that's happening, it's exerting radial pressure onto the cervix, which can also cause the release of prostaglandins and helps to dilate the cervix. It can be pretty uncomfortable as it's inserted, as you can imagine. It can cause some cramping, contractions, spotting, all of that. Sometimes providers can insert this like at a clinic visit or at like a birth center, and then they would have the patient go home and come back in 12 to 24 hours for removal. Not very many providers offer this as an option. I mostly see this at like with home birth midwives or maybe birth center midwives, but not like in a hospital setting. So just another option, but again, not a common one, at least not here. And then we're going to talk about balloons. So there is the Cook catheter, and then we'll also talk about the Foley catheter. This is a great picture of what the Cook catheter looks like when that has fallen out of someone, and then you can see that animated picture of like the placement. So a Cook catheter has 2 saline balloons that you would inflate with saline, and each balloon is on either side of the cervix. So this catheter goes through the cervix, and you're going to inflate 1 balloon on the inside and 1 balloon on the outside, and those 2 balloons put pressure on both sides of the cervix to help thin it, soften it, release prostaglandins, dilate, all the things. So this can be left in for about 12 hours, and usually when you get to about 3 to 4 centimeters dilated, it will fall out on its own. When this catheter is in place, you can usually move around like normal. Often they're going to do continuous monitoring, as sometimes it can cause overstimulation and like too many contractions. And you're probably going to feel a lot of pressure and a lot of cramping. And honestly, this can be probably one of the most painful induction methods that exists. And it's because we're really like manually dilating your cervix, and that is not going to feel good. Sometimes, I mean, I've seen a lot of inductions, and I will say with balloons, either people tolerate them fairly well, and it's not that big of a deal, or it's the most painful part of their whole entire labor process, and it is very painful and really like the one negative thing that they kind of wish they didn't ever have to do. So I wouldn't just like sign up for this just because. I would carefully consider all your options and try to kind of do all the other steps first. Like if you need a catheter, fine, then let's do it. But if you don't, if you are able to do as many doses of Cytotec as possible, or Cervidil, and whatever else is an option to you, and then see after you've given it a day where your cervix is at, and maybe it's soft enough that then you can just go to Pitocin and potentially skip a balloon altogether. That would be fabulous, because what I see a lot of times with balloons is that it is so painful that, and you're probably like 1 or 2 centimeters, right? You're not very far. You're not really even in early labor yet. And it cranks the pain up from 0 to 75. And now people are like, oh, I can't do this. I can't cope. This is hard. And they might even get an epidural. at 2 centimeters, or call their doula in for support when they're not really even in labor. It's just the balloon that is causing the pain. And once that balloon comes out, they're fine again. They're fine. They didn't need an epidural. They didn't need support. It's not because they're in hard labor. It's because the balloon is that uncomfortable that often it pushes people to those interventions when they're really, really early on. So that is my kind of caution with balloons. Again, my personal experience. So same with the Foley, which we'll get to in a minute, but the Cook catheter and the Foley, they both are going to fall out when the patient gets to about 4 centimeters, because that's like how big the balloon is blown up, is to about 4 centimeters circle. And so when your cervix gets to that point, the balloon's going to fall out. And then, well, hold on, we'll talk about it in 1 second. Okay. Let me talk about the Foley first, and then we'll get to that point. So Foley is same idea as the Cooks, except it's just one balloon instead of the two. So a Foley, we know this because it's often used to empty a bladder. This is more used off-label for labor because the Cook's catheter is for labor use specifically. The Foley is not. The Foley is more like a bladder drainage catheter, but they can use a Foley on a VBAC candidate. So the Cook's is technically not supposed to be used for VBACs. Again, you might see different things in different states, but here in Washington, Foley bulbs they can use because it's off-label, so they can use those for VBACs, which would be a reasonable choice because remember, VBACs can't have cytotech or anything that's going to thin the cervix, and so they're kind of out of a lot of options, and so then a Foley is probably a good option for them. This is going to cause a lot of the same things as the Cook because it's doing the same kind of idea. It's left in place for, up to 12 or 24 hours. You can usually move around as normal, but you're going to feel that pressure, that cramping. Again, it's pretty painful. Sometimes if it's really painful to place it, I can remind the client that is there nitrous available at your facility? You could try nitrous for the placement of this. Sometimes people will opt for an IV narcotic just to kind of get through the placement and relax their body down to cope with this. Okay, once these catheters come out, the next step usually is Pitocin because again, they're around that 4 centimeter mark. Yeah, so same kind of idea, just two different ways to go about it. And then here's where I'm backing up where I had left you off before. So the Foley 4 is what it's called. And this is also true for the Cook's catheter. So remember, those catheters are going to fall out when you're around 4 centimeters. And because that dilation was manually forced, it's going to take your uterus a long time to catch up and start making progress past that point. So a lot of times parents get excited because the catheter falls out, big excitement, I'm 4 centimeters, yay, something's happening. And they're probably feeling some contractions by this point, but it's not the contractions that got their cervix to 4 centimeters. It was the balloon. And so we need to tell them your contractions have to catch up all the way to what they would have needed to be to make your cervix 4 centimeters. And then they need to get harder past that point to have further progress. And so often when these catheters fall out and you're 4 centimeters, you're going to have a huge, long stall. It's not really a stall, but they might feel that it is. And it's because we have to really wait for your uterus to catch up to that. So sometimes providers will recommend starting Pitocin with a catheter. Sometimes they let the catheter do its job and then start Pitocin after it falls out. Doing Pitocin with a catheter is going to be a lot. That's going to be a lot all at once. So I would highly recommend nitrous or some kind of pain management for that. There's really, like, it's okay for your patient to advocate that they maybe want to separate those things so that they can stay on top of pain control if that's important to them. So the balloons come out, and then we kind of see how things go, and it depends too on their unique situation and maybe how soft their cervix is and how thin it is, and have they had a baby before, and just the whole big picture. Sometimes if someone's had a baby before, all they need to do at this point is like maybe break your water, and then that's just going to kick them into labor, and they don't need Pitocin at all. If it's their first baby, they might definitely need Pitocin, and that's a whole nother conversation that you can have, pros and cons about, like, should we break water or should we try Pitocin, or which route should we go? But just know it's pretty common starting Pitocin at this point, and you might need hours and hours and hours of Pitocin to get those contractions strong enough to start making cervical change past the 4. So if like 4, 5, 6 hours goes by and there's still 4 centimeters, that's okay. I would expect that, honestly. That's pretty normal. And so that is a good thing to prep your client on so that they don't get discouraged about, oh, nothing's happening and why am I not progressing, and feeling discouraged. So that's a lot of information. I will say it's the bottom line here, I found in a Cochrane review that for women undergoing an induction of labor, the Foley catheter is less effective than oral meso, and the Foley was associated with fewer vaginal births. So I agree with that. I say to my clients, if you want my opinion, I would avoid a balloon at all costs, because often it's just the providers that are not being patient. They don't want to wait. They don't want you in there for days. But if you're in there for days, but mostly you're waiting around for cervical ripening and you're not in hard labor, that's okay. People can do that. I would rather have my patient get a day of 24 hours of meso and then start Pitocin than have a balloon and have their pain ratchet up and need an epidural at 2 centimeters and everything feels like it went out the window, and they're it's just a whole nother ballgame. So again, you're going to hear a lot of my opinion on here. I'm trying to at least tell you what my biases are so that you know what's my opinion versus what is actual facts. Okay, we will talk a little bit about monitoring contractions. So when you're induced, it is important to monitor contractions, usually continuously, because we are causing contractions and we want to know how baby is responding to that. We want to make sure that you're not, contracting too much, too frequently, all those things. So for sure, once Pitocin is started, it is continuous monitoring. With cervical ripening agents, usually it's like the first couple of hours, and then they might let you be off of it for a little bit. So if you look at this strip of monitoring, you can see on the bottom, that is what's going to show your uterine contractions, that little hill. And then above that is the baby's heart rate. And so they are looking to see how frequently you're contracting, how long they're lasting, but they're also looking to see how your baby is responding to those contractions. Like, does the baby have a dip before, during, or after the contraction, and each of those can mean different things to them. So I want to point out that this way of monitoring with the external monitors, where they're going to have like a belly band with, one measuring contractions, one measuring baby's heart rate, that is just telling us on this graph that they are having contractions, how far apart they are, how long they're lasting. It doesn't tell us how strong they are. So even though you see that little hill, and some of them are going to look small and some of them will look really big, that doesn't mean that they're strong or weak. We can only tell that if we have an internal monitor inside their uterus. So sometimes that's good. It's really good for you as a doula to know that, but it's also good to tell the parents that, because often they don't know and they think, oh, these are really strong. That must mean I'm in hard labor, when it doesn't mean that at all. It could look huge and you're in early labor. It could be little tiny baby ones and you're in transition. So just telling that to them, especially the dads, because they're like, oh, that was a big one. And so that can be helpful for them to know. Okay. Sometimes they'll see these contractions like with the meso or a balloon, or the early or pre-stages of labor. Their nurse might get all excited and say, oh my goodness, are you feeling these? You're having contractions, and get the client kind of amped up of like, oh my gosh, I am having contractions and I'm not even feeling them. So I must be just like coping really well. And this is moving right along. And really, that's not the case. Pretty much everyone is going to have some contractions when they're pregnant on a monitor. And that doesn't mean that they're in labor. It just means they're having some contractions. And it's normal for them to not necessarily feel it in the beginning. So kind of prep them on that. Okay, that is that. Now we're going to go on to the internal monitors. So these are going to be the ones that go inside to accurately measure contraction strength. And this on a graph would definitely tell us for sure how strong they are, because this is called an IUPC, an intrauterine pressure monitor or catheter. It's a thin, flexible tube that just goes right into the uterus next to baby. It doesn't like connect to baby or anything like that. It's just in there next to. And this measures the strength and intensity of the contractions by recording the pressure within the uterus. So that is tracked by calculating MVUs, which is a whole like huge mathematical equation. But basically, this is going to tell us if contractions are considered to be adequate or inadequate. And if they're inadequate, that means, oh, your contractions aren't strong enough mathematically, pressure-wise, that we would expect your cervix to be changing from that. That can be sometimes good information to know, or maybe they're adequate and you're not dilating, and that is indicating maybe there's something else going on here. So this can be especially helpful if you're on Pitocin, especially higher doses of Pitocin. This can make sure that they're using it appropriately, that they're not like overdosing Pitocin, because that could cause problems. And so obviously this can't be used until the water has broken, because it has to go inside the amniotic sac, but is often comes up with inductions, especially longer ones, and can be a good tool to help us use Pitocin in a good, safe way. Obviously, it's going to slightly increase the risk of infection with any time you have something going inside, but really rare for that to happen from that monitor. Okay, Now, this is what I would tell my client for tips on how to navigate this cervical ripening stage. I would tell them to eat, hydrate, sleep, ignore, and repeat. So, this cervical ripening stage easily can last 12 to 24 or more hours. It is not a fast process for most people, especially a first baby. Often hospitals will start inductions at night, and that's because they know those first 12 hours, like there's not much happening. And so the goal is for them to sleep. So sometimes that makes parents confused, but it makes sense and is a good idea to sleep through the first 12 hours if you can. So this is a great info to kind of share with your client about that. A pro tip, if you are checking in for a night of cervical ripening, so this is what I would tell my client, I would highly recommend they ask for a sleeping aid. So again, this is my big bias, but also a pro tip. Depending on your birth location, this could look like Ambien, morphine, Nubain. Those are the better, longer acting medications that can help with sleep. Often, almost everywhere will offer like Benadryl or fentanyl or something like that. Those really just aren't enough to cut it, and they're pretty short acting, whereas the other ones are gonna like last through the night. Fentanyl or Benadryl are gonna last like maybe 1 to 3 hours, and just not really give you the bang for your buck that you're needing. So remember, you're in the hospital, but you are not in labor. It is super hard to sleep. Your nurse is going to be in and out of your room every couple of hours to adjust your monitors, give you another dose of medication, take your vitals, all this stuff. You're going to have lights and beeping from machines and monitors. There might be like a loud laboring patient next door to you that is keeping you awake. You are going to be in the super uncomfortable bed. This is not going to be a good night of sleep. And you're not even in labor yet. And so getting a really bad night of sleep the night before you know you're going to be in labor is not a great idea if you can at all help it. And so honestly, sleep. I say if you are hoping to go unmedicated, sleep, especially in this early part, is literally essential. That could be the reason that you get an epidural, is just because you did not sleep well that night. And so I know there are a lot of people who feel strongly about narcotics or feel strongly about sleep meds or meds in general. But this is one of those situations where you might want to weigh the pros and cons, because would you ask yourself, would you rather get a sleeping pill or some medication to help you with sleep and then go on to have your unmedicated birth versus not get the meds, not sleep very well, and then possibly end up getting an epidural because you're too tired? So of course, it can be done. Anything is possible. But in my 16 years and 900 births, I will say that if you do not get a good night of sleep before labor, it's very, 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 very difficult to go unmedicated. Okay, what should your client do and focus on? Again, this is another really good slide to show your client, to give them some tips on what to do. I would suggest that they make their room really comfy and cozy so they can add like twinkle lights or battery candles. Definitely bring their own pillow, maybe even a soft blanket. I would get comfy in your own jammies. You could put some soft music on. Some people like to wear an eye mask or have earbuds, just kind of like tune everything out. You could have something that you like to smell or oils or whatever. And then really be mentally prepared for this to take a long time. This is not a fast process. Inductions are long and they are slow, especially for a first baby. And I think if you are mentally prepared for that, you're going to cope so much better and really kind of think, okay, slow and steady wins the race. um, and it takes time, and that is okay. It's not bad. Also, ignore all sensations, all cramps, all contractions until they become hard enough that you have to focus on them and you have to cope. If you were at home in early labor, you're going to be ignoring as long as you can, right? Trying to sleep, trying to rest. You want to ignore it until you can't ignore it anymore. And then, guess what? You're still in early labor. So ignore all this like pre-labor stuff that the induction will bring, and wait until you have to focus on things to focus on it. You can utilize nitrous or IV pain medication to get through balloon catheters if needed. That can make it so that you can maybe keep some more mobility as long as possible rather than jumping straight to an epidural. You can ask to take breaks from monitoring. You can eat, you can take a shower, you can move around a little bit more if you kind of need that like mental break. That can feel really good. Don't recline. A lot of people don't like this advice, but really I recommend that the mom try to stay more forward leaning. So like sitting straight up or side lying if she wants to relax. It's better to be on her side than laying on her, reclined. That's going to help with baby positioning. So just remind her, try not to recline. And then bring entertainment, bring books, podcasts, movies, word puzzles, games, all the things to keep them occupied during this huge waiting stage. And then again, sleep, sleep, sleep. I'm going to hit it home again, ask for a sleeping pill or something to help. Most people have a hard time getting a good night's sleep for that first night, and you do not want to have a bad night of sleep before going into labor. So sleep, ignore, hydrate, repeat. Okay, I digress. I think you get the point. Okay, we will talk a little bit about breaking water because this is often an intervention that is recommended or suggested because that helps to release prostaglandins and hormones, which can just help and aid in like keeping this labor going. So it's also like a little bit more of a natural intervention than like going to Pitocin. So when that bulgy bag of water is gone, it allows the baby's head to further come down into the pelvis, and that baby head then is going to put more direct pressure on the cervix, which is also going to help the labor progress a little bit faster. So those are some of the pros of breaking water. The cons would be that it can make your contractions feel more intense, and of course, once the bag is broken, it's broken. We can't put it back together. And then the chance of a uterine infection can start to go up. And so it can kind of like put the mom on on the clock situation. Every provider and hospital is going to be a little bit different on what that clock looks like for them. Statistically, the chance of getting a uterine infection from your water breaking starts to rise around that 18 to 24 hour mark. However, it could happen at any point. So I have seen people with their water broken for like 2 hours and they get a raging infection. Um, and then I've seen people with their water been broken for like 45 hours and like don't have an infection at all. So we don't know what will happen. We can't predict that, but having it broken and the longer it's broken is going to increase the chance of infection happening. If an infection starts happening, we will know that because you're going to be showing signs of usually your heart rate goes a little elevated, you're going to spike a fever, your baby's heart rate might be elevated and like sustained elevated baseline heart rate. And that doesn't necessarily mean you have to have a C-section. But it also kind of depends on where you're at in labor. If you're close to delivery, usually it's fine to just, okay, let's just try to get this done and push this baby out. If you're far from delivery and your baby is showing signs of also being affected by that infection, like their heart rate's going up, that's a little more tricky because they don't want that to be going on for hours. And so that means like delivery needs to be a little bit more imminent. So, also, if you have an infection, it sometimes means that your uterus isn't going to contract as effectively. And so sometimes it just makes your contractions like not as strong as they should be, which can then also, end in progress not being made. So, just we don't want an infection. Obviously, nobody does, but knowing like the risk is higher if we break the water. So trying to do that at like an appropriate time with, for a good reason. I personally would not recommend breaking water before 4 centimeters for sure, but ideally more like somewhere between 5, 6, 7 centimeters for an induction, I think is a good appropriate place to do that intervention. So that is my personal opinion on that. And then here are some things to think about before breaking that bag of water. You want to talk about your medication plan. So if the client is hoping to avoid an epidural and hopes to go unmedicated, breaking the water can be beneficial because it could kickstart her own labor, which could be a more gentler process consisting of her own natural hormones. So if she's already like 3 to 4 centimeters, it could be a reasonable option if she's hoping to possibly avoid Pitocin. That is going to work best if it is not a first baby. Okay, baby positioning. It's always a good idea to try and assess baby position before breaking water. So the bag of water is going to give cushion, which allows the baby to better navigate into the pelvis and change positions. If we know that the baby isn't in a great position, which sometimes we can tell by contraction pattern or where she's feeling it, or maybe the provider can give us some insight on if they do a cervical exam. Sometimes they can feel the position of baby's head and which way they're facing and all of that. So if we know the baby's not in a good position, it is a good idea to avoid breaking the water and work on positions to help that baby rotate first. Because once you break it, that baby's going to sock down into that not ideal position, and then it's going to be way more difficult to get them to rotate. If the baby is not in an ideal position and you break water, it can make labor stall, or it increase the chance of an instrumental delivery or even a cesarean. And then lastly, which we kind of touched on, infection risk and time frame. So although we never know how fast or slow labor will be, the closer to active labor, which is 6 centimeters, the chances of labor being more imminent is good when they're 6 or more centimeters. And that is going to mean probably less risk of infection than if you broke it at like 3 or 4 centimeters. Of course, infection could happen, like we said, at any point, but the earlier we break it, the higher the risk, and that can sometimes impact the mode of delivery. Many providers will want to start Pitocin and break water at the same time. If you're wanting to go unmedicated, I would not advise that. Let's do one at a time, because that's, again, like ramping way up from 0 to 60, which could be really hard to cope. And you probably don't need both at the same time. Now, if they are comfortable with an epidural, go for it. If it's not their first baby, you probably don't need to do both at the same time. One or the other is probably enough. So, again, slow and steady wins the race. Let's be gentle with our bodies and not overwhelm them. Okay, now we're going to move on to Pitocin. Pitocin is the synthetic form of the hormone oxytocin. Pitocin causes the uterus to contract, which can help induce labor, augment labor, control bleeding, etc. Pitocin for induction, it is given through an IV. Usually that IV is in the arm. And it started at a low dose. So this is always really good to go over with your client, because sometimes, they're reading really scary stories or things about Pitocin that aren't really accurate. And so we want to prepare them I don't want my clients to be scared of Pitocin, because sometimes it can be a really good tool that will get them their vaginal birth. So it is started at a really low dose, so usually 1 or 2 milliliters per hour. The nurse is gradually going to increase the dosage, usually by 1 or 2 units, every 30 to 60 minutes, until you're having regular contractions, which to them means about 2 to 3 minutes apart, and then they'll stop it. So their goal is to continue increasing Pitocin, but only once or twice an hour. And then once you get into that regular contraction pattern, they leave it where it's at, and they don't increase it anymore unless they need to. Now, if your baby reacts negatively to these contractions or contracting too frequently, they can lower it, and it is in and out of your system really fast, and so they can control it very well that way. Usually once we kind of get you to that solid contraction pattern and we leave it there, usually you're just on that dose until you deliver, but we can adjust it if, again, your contractions become too close together, or maybe they get far apart again and we need more Pitocin to increase them to come more often. So that is kind of how Pitocin works. A lot of people are really worried that they start really high and that you just kind of go from 0 to 60. And it's also really important to know your client can advocate for themselves on what does this look like to them. Like, if they usually start at 2 and go up by 2 every 30 minutes, like maybe they want to start out at 1 and go up by 1. It doesn't there's not a rule of what we have to do. The dosing can be adjusted a little bit, and kind of within the parameters that your client wishes to use it. So if things are starting to kind of ramp up and get hard and they're having a hard time coping, or like things are really like, whoa, this is active labor now, but maybe your contractions are like 4 to 5 minutes apart and they're not at 2 to 3 minutes apart, it's okay to say, can we hold off? Like, can we wait an hour and not increase and kind of like see where we end up? Because maybe my body is on its way now and it just needed that little nudge, and it will do it on its own. And we don't need to keep increasing. So just know it's a conversation. It's not black and white. We can discuss what is appropriate for them. So things to do for your client is ignore and nap. So Ignore contractions as long as possible. Um, they might feel their contractions starting as soon as 30 to 60 minutes after Pitocin is started, or sometimes people don't really notice them for many hours. So always try to get that one last nap in when Pitocin is started, because we don't know like how long you have until you're really feeling it. And then after your nap, distract yourself. So continue, like, don't focus on it. It's hard to do that in a hospital because everyone's so focused on every little sensation, and you're already there. Everyone's looking at the printout and the chart, and it's just not an environment set up for you to ignore this well. So imagine, like if you were at home, what would you be doing in early labor, and try to do that at the hospital. So movies, music, games, books, stuff like that. Do that as long as you can. Again, eating, hydrating, peeing, do all of that as much as you can. And then when things are starting to kind of turn the corner and get harder, and you can't really ignore them anymore, then you can start utilizing labor positions. So using a ball, going for a walk, doing some stretches, lunges, circuits, all of that, and really kind of try to change that position every 30 to 45 minutes is my recommendation. So, and really you can kind of even incorporate position changes even while you're distracting yourself. So maybe like have a movie on and do some stretches or some lunges, or be playing a game or listening to a podcast or whatever, and be kind of incorporating those things together is my best recommendation. Okay, Pitocin it's administered via an IV, which we said. Everyone who checks in for an induction is going to have an IV started, and the Pitocin is in a pump, so it automatically does all the dosing, and she just increases it and changes it as it's needed. You're going to have to be on continuous monitoring, so that is going to watch your contraction pattern and baby's heart rate, and it also tells us how your baby is tolerating these contractions. A lot of hospitals have telemetry units for monitoring so that you can still be mobile and get out of bed and walk around, or even like shower or take a bath with them on, which is lovely. If you are induced, I highly, highly, highly recommend asking for the telemetry unit. Now, if you're like going to bed and trying to sleep, the monitors are fine that are hooked up, the wired ones, because you're in the bed. But as soon as you're like, okay, I'm up, I'm moving around, I want to be mobile, ask to switch to the telemetry. Okay. Your movement is probably going to be at least a little restricted, and that's because you have an IV. You're going to have to kind of like carry that pole around with you. You have to have continuous monitoring. So, you're going to have some wires, you're going to have like some attachments, and it's just kind of a little bit of a hassle. So just it is what it is, and that's how we can do these things safely. And it's not too bad. So just one of those kind of bummer things about being induced. There are a few risks associated with Pitocin. So it can cause your uterus to be overstimulated and contract too strongly or too often. That could result in a placenta abruption, where your placenta starts to detach before its time, or even a uterine rupture. Those both are rare and more likely to happen if you have had a previous C-section. Even still, the chances are very low. If your uterus is contracting too strongly or too often, your baby might not tolerate it, and that they would respond to that by like having a change in their heartbeat, which could be concerning if it's going down too low or too often or for too long. So to remedy that, they would either lower the Pitocin or turn it off altogether, let the baby recover. And usually if then the baby looks good for about 30 minutes, they're okay to restart the Pitocin and try it again, usually at the smaller dose again and like slowly incrementing up, and see how baby tolerates it. And if baby is still having problems, then we might have to have a conversation about having a C-section, because you have to have contractions to have a baby. And if we can't give you contractions because your baby won't tolerate it, then we're kind of stuck, right? If your baby has a really big dip in heart rate that is not recovering and not coming back up even after they've stopped Pitocin, then obviously that's going to be probably a cesarean done much more urgently. Sometimes that can feel really scary, but you're in good hands. Obviously, your client, you know what I mean when I say you. And so, again, that can happen in any birth, even without Pitocin, even without an induction. So, just crazy things happen. Okay, sometimes some people say that Pitocin makes contractions more painful. I think that there are a lot of factors to this. Like, personally, this is my opinion. I feel like inductions are not the same as if your own body went into labor. When you go into labor physiologically, you're going to have a whole like set of hormones that are happening, which I call like this labor hormone cocktail. And you're not getting that same cocktail when we're inducing you, because now this is synthetic and we are causing and kind of forcing your body to do something that it wasn't quite ready to do yet. So, although it might not hurt more, your body, your mind, your hormones are not in the same place as if this was occurring naturally. And I personally think that that matters and can be a factor. So I would describe Pitocin to be causing your contractions to feel like maybe a little sharper, and like a sharper peak instead of a gradual rolling hill. So if you went into labor on your own naturally, usually your contractions are like a nice slow build to the peak, and then it's going to slowly come down, right? Whereas Pitocin, it's more like ooh, up really high, a little bit more sharp and steep. So that can feel different and be a little more abrupt. But as far as strength goes, I feel like your body needs really strong contractions to have a baby. And I don't feel like Pitocin in general is going to make them way more stronger. I just think that it's those kind of factors of like it not being gradual. You don't have as much of a build up to labor as you do when you go into labor on your own. And that, you know, it's not your own like hormone cocktail. And I think those factors right there just make it feel a lot different and probably hurt more to some people. But also, if you ask someone who had a baby unmedicated, without an induction, they're still going to say it hurts really bad. Okay. Risks of Pitocin, which we kind of already said some, but here are a few others, would be that some studies have suggested that there's a higher instance of postpartum depression and anxiety when Pitocin is used, and possibly less success with breastfeeding. There's still a lot more research that needs to happen for that. And then the longer that you're on Pitocin, the greater chance you have of having increased bleeding or a postpartum hemorrhage. A recent study showed that women who were exposed to Pitocin for 12 or more hours were 52% more likely to experience a hemorrhage after delivering their baby. I have heard some providers actually mention this to clients who are being induced and say like, well, we don't want you on Pitocin forever, or maybe that's a reason why they kind of want to ramp it up faster, or be a little bit more aggressive with it. But, and yes, that's true. Like, that is true that studies are saying there's a higher chance of postpartum hemorrhage if you've been on Pitocin for a really long time. However, if that's the reason for like pushing you to a C-section, having a C-section, especially a C-section after you've been on Pitocin for a bit, is also going to increase your risk for a postpartum hemorrhage. So, have a conversation. Pitocin definitely has a bad rap in lots of social media circles and like just in the general population. But I think it can be an extremely useful tool when needed, and it's often very successful in helping women to achieve a vaginal birth. Okay, now you might be wondering when to join your client through all of this. So I would talk to your client prior to the induction, kind of give them a lot of a whole like induction talk and like really go through what's going to happen, what to expect, so that they're set up for success and kind of have wrapped their brains around that a little bit. If you have a TENS unit or more than one, I usually let my clients borrow one so that they can use that kind of in those early phases, especially if they end up getting a balloon catheter or something like that. Sometimes that can be a really good tool to help them kind of cope through some early uncomfortable stuff before they're like really in labor. And then think of like what kind of comfort items you could help them come up with or bring or pack for their stay. I would hand hold them over text and phone support through those initial stages. I would check in, answer questions, offer encouragement, kind of gather the plan, really help like if you were there, but you don't often need to be there through the whole early stages because again, they're probably going to be there for a whole day of just kind of like waiting around not in labor. And so I think having like that talk beforehand of setting really good expectations can help so that they know what to expect and like what to expect from you and when to expect that you will join them. So I tell my clients that I will join them when they are needing in-person physical and emotional support. So I kind of say I treat inductions like normal spontaneous labor, and I join them when they need me, which is usually at, the middle to end of early labor or at the start of active labor. So I don't have like, you have to be so many centimeters or any kind of criteria like that. I will come when they want me, but I remind them that they probably won't need me there for quite a while. And if they were to go into labor on their own, I'm not going to join them at their first contraction. Like, we're still going to do all this text and phone support and like offering position changes and reminding them to sleep and eat and do all of this until things get hard, and then I join them. So same for an induction. I remind them to tell me all the things that are happening. I want to know every cervical exam, and I ask them, like, ask the nurse if you don't know, like, what was the dilation, what was the effacement, what was the position of your cervix, where's baby station, and then I sometimes will ask for contraction patterns and offer guidance on positions if it seems like baby needs to rotate. So sometimes they'll literally like take a screenshot of their strip, their contraction pattern, or sometimes I'll have them use their phone and do like a contraction timing app and send me that. So whichever works for you and them is fine. And then I'm always available for a phone call if an intervention comes up or is suggested and maybe they're not sure what to do, or maybe they just want to like talk it out with me. I remind them that they can always tell the nurse and provider that they would like a few minutes to chat with their doula and discuss things and kind of like make a decision that feels good to them. That is totally fine and appropriate. And if they are going to break water, especially if they've already been on Pitocin or if it's not a first baby, that is usually a really good time for me to head to them, as sometimes things can escalate quickly. So either labor progresses quickly or the contractions intensify quite a bit. So I like to be there when they need me instead of like they need me now and I'm, 45 minutes out or whatever. So those are just some of my personal tips on when to join your client. And then again, I've given you already some tips that you can give to your client, but here's just a few more before we kind of wrap everything up. I would mention to them to ignore everything as long as possible. Slow and steady wins the race. Eat, sleep, hydrate, super important. I definitely recommend just kind of switching to electrolytes in labor, like high quality ones. And then distracting themselves, movies, games, all that. Bring comfort items from home. That can be really, really helpful, especially in that kind of day of waiting. And then once things get active and they can't ignore anymore, that's when they can be active too. I don't want them being super active in early labor or in pre-labor, because that's really when they need to be banking up on their sleep and wait until active labor to be active. And then remind them, don't be afraid to use sleeping meds or IV pain meds if they need them. Like, those are a tool that is there for them to utilize if they need it, and do not feel bad about that. Sometimes, remember, we're weighing the pros and cons of if that is going to enable you to hold off for many more hours on an epidural, then that's great, because that's many more hours that we can be mobile and do positions, right? If they're trying to avoid an epidural, then maybe that's what enables them to get some sleep to have their unmedicated birth. So nothing is bad or wrong. They're all just tools and choices that we can utilize what we need in the moment. And that, my friends, is my little talk on induction. So if you want more content like this, you will love my Elite Doula community. So this is a membership, and it's a community of like-minded doulas who want to expand their knowledge in all birth topics, learning how to best support their clients, build and sustain a thriving birth business, and become experts in the field of birth. So what do you get with this monthly membership? You are going to get a monthly mastermind topic just like this one. So each month I'm going to have a topic, and it might be like a continuing ed thing. It might be a deeper dive on like high risk clients or gestational diabetes, or it might be on like contracts and backups, or like what to do if your client is unhappy with you, or there's a million things we're going to talk about, and I'm really excited. So each month we're going to have a topic like that. And that topic, I'm going to do a webinar just like this that only members are going to get. And then we are also going to have a 2-hour-ish long deep dive on that topic. So after you have watched the webinar, I'm going to give you about 2 weeks to watch it. And then we're going to all meet up via Zoom and have a deep dive conversation about the webinar, where I answer more in-depth questions. I elaborate more on things. It's going to be like good discussion and learning time. And then You also will have access to me directly to help you with your business questions, or if you have a client that has something come up and you're not sure what to do, you will have weekly access to me. And then we'll, of course, have our community where we have our own whole app where we meet and chat, and encourage each other, and it's amazing. So I would love to have you be a part of that. And if you have any questions, please feel free to ask me. You can email, you can find me on social media, all the things. And that is it. So I hope that you learned a lot. Um, I hope that I taught you something new. That is definitely my goal. And if I taught you a lot of something new, amazing. So I would love to hear your feedback on this. If you felt like I missed something or didn't elaborate enough on something, or if there's anything I need to change, I would just love your feedback. So yeah, message me, let me know how you liked it, and I hope to see you inside the Elite Doula community. All right, have a great day, everybody.